that I'm going to record.
Our attendees. Today, really, I am going to discuss some cases related to cardiac patients or to cardiology, because I have informed before I preparing this lecture, today will be related to a special topic or cardiology topic. And so I try to select some cardiac cases for this webinar. My slide is apparent now, Dr.
It is, but we need to see the presentation, Prof.
Yes, I try to share. Share.
You shared already, but you need to show the slide, the presentation itself, please. Yes,
Okay,
thank you. Thank you.
First case, 60 years old man in ICU with 40% total body surface area burn, and he returns from the theater following an extensive debridement procedure. Esophageal Doppler has been inserted, and the nurse has requested a review of the reading or last reading. And the heart rate is patient exhibiting tachycardia. Cardiac output is 3.8 liters per minute, low, and stroke volume also is low. Corrected flow time is 262 meters per second, and the peak velocity is 58 centimeters per second. What intervention would you advise? Of course, from the clinical evaluation, the patient is tachycardic, low cardiac output, stroke volume is low, maybe low cardiac output to many causes, maybe hypovolemic, maybe may need inotropic drugs, maybe hemorrhage, maybe cardiac tamponade, and so on. But the corrected flow time here is low, 262 meters meters a second, and this reflects the hypovolemia because it is low. The normal range of about 320 to 360, Peak velocity also is low, 58 centimeter per second. And this data can be predicted only by Doppler. And so we have to proceed to give this patient some fluid to correct the hypovolemia which he suffered from. 500 cc fluid challenge given, and his low stroke and short corrected flow time heart rate correlate indirectly proportional to manner of preload, suggest hypovolemia as a cause of the low cardiac output. And so this fits with the clinical scenario, hypovolemia following 500 cc fluid challenge, his cardiac output, stroke volume, and corrected flow time improved to some extent, and indicating a positive response to filling. But there is another point, which is the low peak velocity, suggests an impaired contractility, and so an inotropic drug is used for improving the cardiac output. And this declares the importance of echo in clarifying the underlying cause of low cardiac output in our cardiac patients. Flow time corrected is a flow time duration of blood flow in the aorta normalized to 60 beats or to normal heart beats rate beats per minute using Bassett's equation. Typically, flow time is 1/3 of the cardiac cycle. When standardized to 60 beats per minute, one cardiac cycle is 1 second, and so the third of 1 second would be 0.33 or 330 milliseconds. This is the normal range for the time corrected or flow time corrected through Doppler. Corrected flow time by esophageal Doppler is considered to be an static preload index and predict fluid responsiveness. A decrease in the corrected flow time means a decrease in the preload, and so we have to give flows. As we know, we have many methods for evaluating the intravascular volume in the ICU patient or in critical ill patient, like pulse pressure variation, blood pressure variation, central venous pressure, left ventricular and diastolic area index, PICO, LIDICO, all this IVC, which is very important through Doppler detection also is very important, and reperfusion index. All these are parameters used or utilized for evaluating the intravascular volume in our patients, in addition to the specific one, which is corrected flow Doppler through esophageal Doppler, and also the peak velocity. And so the corrected flow time predicts fluid responsiveness. A decrease in it means a decrease in the preload, and the normal value about 330 to 360 milliseconds. Flow time corrected is the duration of the time of blood flow through the aorta from the left ventricle during systole. And so if it is decreased, this meaning the volume or the ejected blood is low in its volume. Flow time corrected is flow time duration of blood flow in aorta normalized to 60 beats per minute using Bassett's equations as we showed. Normal range 330 again to 360 milliseconds. The other point, which is a peak velocity, and this is a good parameter for the contractility of the cardiac muscles, and the normal value we can approximately subtract the age from 140, give you the range of the peak velocity. And so the peak velocity in this case is low, and so we started to give an inotropic like dobutamine or norepinephrine or other inotropics which are optimal for the patient. Another case, 43 years old lady who has been has been mechanically ventilated in the ICU for the past 3 weeks because of Guillain-Barré syndrome, becomes suddenly hypertensive and tachycardic. All muscle diseases in the ICU carry the same problems, which are the most popular are, as we know, the pneumonia, DVT, and so must be prophylactically anticoagulated and so on. This patient exhibited low saturation to 78%, and she becomes drowsy. Bedside transthoracic echo is performed and captured, and image is displayed below. The sonographer informed you that the tricuspid velocity is 4.9 meter per second, and the estimated right atrial pressure is approximately 10 millimeter mercury. This is a CT of the patients. The echocardiogram of the patients, and declaring that there is some problem in these patients. I think all of you will agree with me. This patient suffering from some sort of cardiac compression or cardiac tamponade or precardial effusion. And even from the clinical discussion or clinical scenario, the patient is suddenly hypotensive and tachycardic, and saturation going down, and becomes drowsy. And all these clinical parameters, and in a patient bedridden and immobile for a long time, and some muscle disease and so on, all this suggests a massive pulmonary embolism and pushing you to give thrombolytic therapy because the patient is hypotensive or hemodynamically affected. What pathology would you consider based upon the results? As we said, it is mostly massive pulmonary embolism, and you need emergency thrombolysis even without other more investigation like angiography or CT. The still image so significantly dilated. As we see here, the right ventricle is highly dilated, and the interventricular septum is depressed towards the left ventricle. It is normally the left ventricle is circular in its manner, but here it takes the shape of D-shaped, which is especially characteristic to massive pulmonary embolism. And so there is a high right ventricular intraventricular pressure here, pushing the septum towards the left ventricle. And so the capacity of the left ventricle is low, or preloading in the left ventricle is low, and so the cardiac output is low, and consequently the blood pressure is low and the patient is hypoxic. The sonographic for tricuspid velocity, we have to use or utilize the modified Bernoulli equations to calculate the pulmonary pressure, to calculate the pulmonary artery pressure by these equations. 4 times the VTR time power 2 result in we will estimate from it the pulmonary artery pressure in addition to right atrial pressure. And so in this case, we multiply 4 by 25 plus the right atrial pressure yield an estimated systolic pulmonary artery pressure, which is 110 millimeter mercury, which is very high, of course, and highly diagnostic of massive pulmonary embolism. Value above 30 millimeter mercury, we consider it as a raised pulmonary artery pressure. The normal, as we know, not exceeding 20-25 millimeter mercury, and above 70 millimeter mercury is severe. And even without this calculation, as I told, from the clinical scenario, we have to give the thrombolytic patient, especially in a bedridden patient and immobilized patient. However, you don't need this number to make the management decision in this case, as it would be reasonable to thrombolyze an acutely hypotensive, hemodynamic unstable, tachycardic, hypoxic also patient with PE risk factors, and the risk factors, as I said, immobility and bedridden for a long time. In this case, prolonged immobility and described by 2D echo, appearance of D-shaped septum is characteristic. If you want to be more sure, we can proceed to CT angio. This is the characteristic shape of pulmonary embolism. The septum is pushed here to the left ventricle, and so this case of massive pulmonary embolism. Another case, your nurse calls you in the middle of the night regarding 70 years old patient who returned from 2 vessel bypass procedure late in the evening. The patient has a background history of hyperlipidemia, type 2 diabetes, and rheumatic arthritis. The patient has become increasingly hypotensive over the past 4 hours, having initially had a good blood pressure at admission to ICU, but by time he developed hypertension, and he was on 0.08 microgram per kilogram per minute of NORAD. As you know, NORAD is anotropic, alpha effect and beta effect, and inotropic. And this is the ideal one which we use first for resuscitation, and an electively paced intra-aortic balloon, pump balloon, which appears to be working satisfactorily. Intra-aortic balloon, as you know, we're using it especially during cardiac surgery or in severe cardiac decompensation to augment the systolic blood pressure or decrease the afterload during systole and augment the diastolic blood pressure and consequently the coronary circulation. The patient has epicardial pacing wire and is being paced at about 70 beats per minute. There has not been a large volume lost through any of the drain. And this is the main problem, really. When you show your patient to no draining to outside, but you have to suspect the drain may be blocked by some blood clot, and so it is an ocular blood accumulation or ocular blood clot. Despite administration of further 2,200 mL of fluid, and increasing the NORAD rate to 1 microgram per kg per minute with an initial response in the blood pressure, the patient's hypotension is deteriorating steadily and the patient becoming progressively hypotensive. The nurse provides you with the latest pulmonary artery catheter data. What is the cause of the patient hypotension would you suspect and how would you confirm it? If we look here to the pulmonary artery catheter data, you will see heart rate 118, patient tachycardic, mean pressure 49, it is low blood pressure. CVB is high, 22 millimeter mercury. Right ventricular pressure 22/10, and the diastolic pressure here is high in the right ventricle. And I think approaching the pulmonary artery diastolic pressure, which is 12 millimeter mercury. Mean pulmonary artery pressure 16, and the pulmonary artery occlusion pressure is 16 millimeter mercury. And so if we look and concentrate, the pulmonary artery pressures may be approximately the same, like the wedging pressure, which is 16. And so there is some equalization of pressure on both sides of the heart or on both chambers of the heart. Cardiac output is low, 2.9 liters per minute. The normal is about 48. Cardiac index also is low, 1.61. Systemic vascular resistance is 1,970 dynes per second per centimeter time power 5. And so the systemic vascular resistance is very high, maybe from noradrenaline or maybe from the compensation by the patient's through sympathetic overactivity. Pulmonary vascular resistance 220, pulmonary vascular resistance index 397, also they are raised. Stroke volume 25 mL is very, very low. Stroke volume normal about 50 to 100 mL per beat. And so here there is low cardiac output, there are a tachycardic patient, blood pressure is low, CVB is high, 22 millimeter mercury, and the right ventricular pressure, the diastolic, is high, wedging pressure equal nearly the pulmonary artery pressure, and so this picture is characteristic to myocardial tamponade or pericardial effusion. Pericardial tamponade with a retained clot confirmed by performing bedside transthoracic echo. Of course, we have to confirm this. Then the systemic vascular resistance here and the systemic vascular resistance index are raised in compensation and because of NORAD use. A patient was initially stable in return from the theater on support device or على intra-aortic balloon and NORAD, but has become progressive hypotensive, and so pulmonary artery catheter data suggests an extrinsic compressed right heart and raised CVB, elevated right ventricular diastolic pressure that is beginning to approximate the pulmonary artery diastolic pressure In turn, the pulmonary artery occlusion pressure is equal nearly to the pulmonary artery diastolic pressures, which must be less than diastolic by about 1 to 5 millimeters. And so mean arterial pressure, stroke volume, low cardiac output, and the cardiac index with a tachycardia occur because of limitation on the blood volume that can get through compressed right ventricle. And so this is a typical case of pericardial effusion, and this from the usually because of clot obstructions due to leakage from the coronary anastomosis. The worsening hypotension despite fluid resuscitations and raising CVB is also often a clue to this scenario. The source of this tamponade may be ruptured coronary artery suture or a ventricular perforation, and these very common complications in CABG operation. Another case here also is there is no patient coming with no fever, and the patient is mildly confused. A transthoracic echo is performed to try to clarify the cause of the hypotension. A still image of subcostal view is shown below this image, and I will enlarge it. What is the pathology is demonstrated, and the list 3 possible causes of this patient hypotension. This is echo as we see, and I think this is clear. Also, this is a case of cardiac tamponade, as we see here, pericardial effusion here, and the right atrium is compressed, narrow here, and as you know, right atrial wall is very thin and it is easily compressed by any effusion. This is a scale in echo. We can calculate the volume, how much is the volume. And this append I saw in the right ventricle, and this is the left ventricle and the left atrium. ECG beside here will give you idea about which phase, systolic or diastolic, this picture is taken. So this is a case of cardiac tamponade, moderate size pericardial effusion, and the causes are many causes, may be uremic, nephrotic, which is a common, hemorrhagic pericarditis, especially patient on antiplatelets before operations. And we can enumerate many causes for cardiac, as pericarditis, viral infection, especially Coxsackie, infection including TB, drug-eluting stent, inflammatory disorders as vasculitis in cases of collagen vascular disease, or in cases of arthritis, post-myocardial infarction, pericarditis also, which is Dressler syndrome. Also, in cases of cancer, all these can be causes of pericardial effusions, kidney failure, minoxidil, hypothyroidism, heart surgery, and primary tumor. All these can cause pericarditis and pericardial effusion. And as we see here, as I cleared before, this is the right atrium is compressed from pericardial effusion, and this is the right ventricle here, and all the preloading also will be affected, and so there is less preloading and less cardiac output, and CVB is high, and the pulmonary wedge pressure will be high, and so on, and approximating the pulmonary artery pressure or diastolic pulmonary artery pressure. This is a characteristics picture of another case of cardiac tamponade or pericardial effusion. And see here, I think it is more clear here, right atrium is more compressed here in this view, and this scale give you the dimensions of pericardial effusions, how much it is severe or less. If it is less than 10 millimeter, it is mild. If from 10 to 20, it is moderate effusion, more than 20, large effusion. And the importance is not only the volume of the cardiac effusion, the importance is the rate of accumulation of the pericardial effusion, more important than the total volume of effusion. And this causing, if it is more acute, causes more cardiac troubles. Also, a severity of tamponade, we can depend, maybe none, maybe moderate if it is causing right atrial compression only. If it compresses the right ventricular wall, it will be life-threatening and decrease the cardiac output. We have to differentiate from pericarditis, especially constrictive pericarditis. And tamponade, there is a specific pulsus paradoxus and the specific and causal signs may not be clear, evident, like in cases of constrictive pericarditis. This is another case showing some sort of calcification in the pericardium and demonstrate a case of constrictive pericarditis or calcified pericardium and restriction of all the cavity of the cardiac muscles, and so causing restricted diastolic ventricular filling, resulting in increase in diastolic pressure in all four cardiac chambers. Where in the cardiac cycle the image has been captured, we can detect or predict from the coinciding or joined here ECG down in the screen. It is taken here in the systolic phase. Also, we not forget the big triad in cases of cardiac tamponade, hypotension, distended neck veins, and distant heart sounds, increased heart rate. Don't forget the pulses paradoxes, which alternating weak with strong pulse beat. And this is characteristic pulses alternance for cardiac perfusion or cardiac pericardial tamponade. Here also is another pictures of cardiac tamponade. This is another case also of cardiac tamponade. And so don't forget, and this from cardiac tamponade, the X-ray, so we can see the heart taking the pictures of a bottle, water bottle or flask, and related to cancer in the lung or cancer in other sides of the body. And especially in post-op cardiac surgery, don't forget these complications, cardiac tamponade, which can be easy to be predicted and easy to be treated if diagnosed early. Big triad, hypotension, jugular venous distension, and muffled heart sounds, and we have to differentiate from tension pneumothorax, in which also this hypotension and jugular venous distension, but absent breathing sounds. It's very important. Electrical alternance here, as you see. This is another case of pericardial effusion. Signs and symptoms, as you know, of impending tamponade include dyspneic, patient will be dyspneic, low blood pressure, distant heart sounds. The X-ray will give you pictures of water bottle of the heart or flask shape, and dullness to percussion over the left subscapular area, which is called Wart's sign. It's very important. And so we discussed now two cases of cardiac tamponade, and the first case is massive pulmonary embolism. All are related to our cardiac day. I shift now to another case also related to cardiac problems. A 63-year-old gentleman on coronary care unit. He was admitted 4 days ago following an anteroseptal acute myocardial infarction, for which a percutaneous coronary angioplasty and stent procedure was successfully performed. He had been pain-free, and his heparin infusion had been ceased that morning. This afternoon, he became suddenly dyspneic with an SpO2 saturation of 68%, requiring CPAP of 12 centimeter water to bring them back to only 89%. He is tachycardic with blood pressure of 82/47, hypotensive, mean pressure 55, and appears diaphoretic. He is urgently transported to ICU, where he is intubated and placed on SIV, tidal volume 475, P12, frequency 14, FI2 1, and peak pressure 28 centimeter water, given 1,000 ml of crystalloid, and commenced on norepinephrine and 0.07 microgram per kg per minute, and dobutamine 3 microgram per kg per minute. As you know, dobutamine also is a patient which are refractory to norepinephrine inotropic effect. We can add dobutamine if we are sure this is a cardiac element. Dobutamine, as you know, if you give it a patient with hypovolemia, will give you more tachycardia and more hypertension, because it is a vasodilator inotropic agent, because it's mainly beta-1 and beta-2 effect, contrast to norepinephrine, which is an inotropic with alpha and beta effect and more alpha effect. A 5-lumen pulmonary artery catheter is inserted, which yields the following data. Always we're not using now pulmonary artery catheter except in such situations in which there is cardiac problems or there is some refractory hypotension or we have coming from cardiac theaters and the patient in a great problems or during cardiac operations. But in sepsis and so on, we now try to go down with uses of pulmonary artery swan catheter because it may bring some problems more greater than its beneficial effect. This patient accepting this data from pulmonary swan, as you know, pulmonary swan gans give you some pressure indices and volume indices about in the cardiac muscle. Heart rate here is 124. Patient is highly tachycardic. Mean pressure is low. CVB is 6 millimeter mercury. Right ventricular pressure 56/7. Pulmonary artery pressure 56 also over 30, and so it's high. Mean pulmonary artery pressure is high. Pulmonary artery occluding pressure or wedging pressure is 14 millimeter mercury, so it is high to some extent. Cardiac output is low, cardiac index is low, systemic vascular resistance is very high, 1,900, and the index is 3,448, and so pulmonary vascular resistance also very high. Saturation, mixed venous oxygen saturation is about 90%. And so this is a typical scenario in a complicated case of acute myocardial infarctions, or exactly, I think most of you now know what is the diagnosis of this case. I saw here tachycardia, mean arterial pressure is low, all the right side filling pressure are high, right ventricular pressure, pulmonary artery pressure, pulmonary artery, even the left side we have seen will be 14, cardiac output is low, systemic vascular resistance is high, maybe compensation or maybe from the drugs which we use, NORAD and dobutamine. But the clue here to this case is the mixed venous oxygen saturation, which is 90%, which is high. The normal is about 65 to 75%. And so this is a typical case of septal perforation and left to right shunt characteristic scenario for this patient. So the treatment here is to try to decrease the left ventricular afterload, even by drugs or through the intra-aortic balloon counterpulsations to decrease the afterload and augment the diastolic pressure. We can use dobutamine, we can use nitrate if the patient tolerated blood pressure can tolerate. And we have also to admit the patients mostly to cardiac theaters for repairing the septal. And this is one of the mechanical failure after following MI, acute MI. And always we see it in the subsequent days after MI, after 2 days, 7 days, 8 days, we can see sudden drop in blood pressure and the patient deteriorated rapidly, maybe papillary muscle ruptures, maybe septal perforation. It is a mechanical problem, it is a surgical problem, needs surgical corrections as rapid as we can. And so the pulmonary artery catheter data here suggests a cardiogenic shock state with a high right ventricular and pulmonary artery pressure. The high mixed venous oxygen saturation suggesting a left to right shunt and the high right filling pressures, all these suggest some sort of perforation in the septum and the oxygenated blood go from left side to right side. And so we have to use the intra-aortic and the medical therapy just as a bridge to bring the patient to surgical correction in the septum. This is another short case. You are asked to review this patient as his wife is worried about his feet, looks terrible, and he was admitted with shock and an intra-aortic balloon pump inserted. Try to list 4 causes for this clinical appearance. You see this patient was constricted here and exhibiting some sort of foot ischemia, and the beginning of foot ischemia we have to illustrate, you can enumerate 4 causes for this clinical appearance. And I think this sometimes is a common scenario, especially after catheterization, especially after arterial catheterizations from cholesterol emboli, which can occur and not only affect the feet, it can affect the kidneys. The patient coming to you after 1 to 3 days by renal impairment from cholesterol emboli. This is a picture of the foot. And so many causes here we can suspect using sometimes vasopressor, maybe from vasopressor, maybe from emboli, maybe the patient is highly shocked, poor perfusion due to cardiac or peripheral vascular disease, maybe sepsis related, and so this picture in a septic patient with small vessel thrombosis. Yes. Another case, and I think this is the last case, a 70-year-old patient has returned from an inflammatory 3-vessel CABG 4 hours ago. She has remained hypertensive since her return. Any problem, Dr. Saad? Any problem? You hear
No,
me?
you can go ahead. You can go ahead. Yeah, that's fine. Thank you.
Okay, a 70
5 more minutes. 5 more minutes.
5 minutes more, please.
I
It's here something.
Case or no?
Sorry. It's somebody using the.
I can complete this case or no?
You can do indeed. Yeah, thank you.
Okay, a 70-year-old patient has returned from an pump 3-vessel CABG 4 hours ago. She has remained hypotensive since her return. She has a background of type 2 diabetes and hypertensive and mild emphysema. She has received 2 liters of chloride since her return and is on 0.25 microgram per kg NORAD. And you are shown her last pulmonary artery catheter data. What is the aspects which would you check on assessing this patient for the cause of her persistent hypotension, and how would you respond to each one of each aspect? Heart rate, patient tachycardic, main pressure is low, CVP is low, right ventricular pressure is low, right pulmonary artery pressure is low also. Mean pulmonary artery pressure on the low normal, pulmonary artery occlusion pressure 4, low normal. Cardiac output is low and also cardiac index. Systemic vascular resistance is high. Pulmonary vascular resistance is with normal. Stroke volume is low, 31 milliliters. So there is a filling. All the right filling pressures are low. All right filling pressure are low, and the cardiac output is low. This is a characteristic for scenario for patients suffering from hypovolemia, and so this patient mostly coming from theater, mostly suffering from some bleeding, or maybe not taking adequate fluid for replacement. And so you have to check all these aspects. Check the anesthetic record for mismatch of volume lost and the replaced one. And always any patient coming to you in the ICU from the theater, you have to review the anesthetic sheet to see if the fluid is not adequate taken in the theaters or no, or you need more fluids. You have to look for the drugs which was taken in the theater, maybe hangover effect or maybe residual effect of some anesthetic drugs which cause this vasodilatation and causes this hypotension. But in this case, exactly, there is an increase in the systemic vascular resistance, and so this is not residual anesthetic drug effect. It is mostly hypovolemia from blood loss. So you have to look for the drain. If it is more than 400 in 1 hour or more than 200 ml per hour, you have to return your patient to the theaters and rapid interference. Check the coagulopathy. If the patient PTT is high, maybe residual heparin, and he need more protamine for but take care from hypotension, or take care also from protamine rebound effect. Also look for low platelets. He may need both platelets transfusion. Also, hypothermia is a very common factor in predisposing coagulopathy post-op. Acidosis also very important. Also the aspirin and all antiplatelets, which must be stopped 5 days before, or in some other antiplatelets maybe 7 days, but in ticagrelor may 3 days enough. Uremia also, and so the patient may need urgent dialysis. If you also try to correct the hemoglobin to more than 7 grams, and in my opinion, I have to increase the hemoglobin concentration to more than 9 grams, especially in these patients who are suffering from bleeding tendency or from hemorrhagic shock. Patient pulmonary artery catheters reveals hypovolemia, tachycardic patient low CVP, low mean arterial pressure, arterial occlusion pressure low, low cardiac output, low cardiac index with raised systemic vascular resistance and systemic vascular resistance index. And this all is a scenario coincide with hypovolemia or with a bleeding patient and not anesthetic residual, not residual anesthetic effect because the systemic vascular resistance and index is high. This is the normal value for I want to mention and I want to concentrate about the pulmonary swans and so on. But really, I suspect Dr. Magid will cover this area, and so no need to repeat. But be sure from your wedging, if you use the pulmonary swan catheter, you must be oriented with the propagation of it, this raw right atrium, just 2 to 6 millimeter mercury, starts systolic pressure going up in the right ventricular area, and the systolic is still low. After going to the pulmonary artery, the systolic pressure will go up 6 to 10 millimeter or 12 millimeter. Wedging here is about 4 to 8 or 12 millimeter mercury. And this is the wedging which reflect the left side, give you idea about the left side volume and pressure indices. Give you idea about the left ventricular end of the systolic volume, left ventricular end the systolic pressure. And so it is good for evaluating the items of the, or the constituents of the cardiac output and guide you to, for how to manage the low blood pressure or how to manage the low cardiac output states. This is a normal value which you must be oriented with it, and so I ask you to return to this reference to know. Just to summarize here, in right heart failure, high CVP, low cardiac index, high pulmonary vascular resistance. Left heart failure, the patient will exhibit high wedging pressure, low cardiac index, high systemic vascular resistance. In pericardial tamponade, the high pulmonary wedge, high systemic vascular resistance, CVP equal to pulmonary wedge. In hypovolemia, you will find a low filling parameters, low CVP, low pulmonary capillary wedge pressure, low cardiac index, high systemic resistance. Cardiogenic, you will find high CVP, high wedging, low cardiac index, high systemic vascular resistance. In sepsis or anaphylactic or spinal shock, you will find low CVP, low pulmonary wedge pressure, high cardiac index, low systemic vascular resistance in early stage of sepsis. You must be oriented with the normal value of all these parameters to guide you to how to interpret the reading for pulmonary artery swan. And please don't push to put pulmonary swans without interpreting the parameters of it and without get beneficial benefit from its correlation and its prediction. If you find the wedging duration more than 18, suspect left heart failure. Also about wedging, the last point, be sure the wedging is in the zone 3, and this can be in summary. You can be sure you are in correct position if the PEEP and the airway pressure not affecting your wedging pressure too much, and also oxygenation in the wedging position is more greater than in wedging position. I think we have to stop here and go to. Thank you.
Thank you, Professor Ansari. Thank you. Very nice. Thank you. Thank you, Professor Ansari. Very nice talk.
Thank you. There is a noisy. I don't know from where this noise.
I think we have to move forward. We will postpone the question to the end of the session. And now we have to move forward to Professor. We have to move forward to Professor Magid Salah, Professor of Anesthesia and Surgical Intensive Care, presented advanced cardiovascular monitoring in cardiac surgery. Please go on, Dr. Magid.
Thank you, Dr. Magdi, and thanks a lot for the Mega Online Academy team for their support and continuous improvement they are offering to our career. I would like also to thank Dr. Saad Mahdi for his support, and thank you, Dr. Samir Al-Ansari, for your nice presentation. My topic will be advanced hemodynamic monitoring in cardiac surgery. We all know that hemodynamic monitoring and adequate volume therapy and the use of positive inotropes and vasopressors are the basis of perioperative care in cardiothoracic anesthesia and intensive care. Guidelines many years ago was published in Germany, classifying the cardiac surgery and intensive care monitoring into basic and advanced. In this basic monitoring algorithm, we will see that ECG and the pulse oximeter and capnography and invasive blood pressure and central venous pressure and temperature measurement, fluid balance hourly and every 4 hours after stabilization, ABG on ICU on admission, central venous line oxygen saturation are the basic monitors that every cardiac surgical patient should have in the operating room and the intensive care. Then the same guidelines defined the indications for advanced hemodynamic monitoring. It was said that in coronary artery bypass grafting, if we have hemodynamic instability with ST segment elevation, I should use transesophageal echo in intubated patients and or transthoracic echo in non-intubated patients, and 12 lead ECG with central line mixed oxygen saturation monitoring. But if I have low cardiac output syndrome pre or post-operatively, or I have a very high risk surgical patient, I need transesophageal echo in intubated patients, transthoracic echo in extubated patients, central venous oxygen saturation, and added pulse contour analysis and pulmonary artery catheter, especially in right heart failure cases. Also, if I have a valvular defect plus coronary heart disease, so I have a combined coronary and valve surgery, or I'm having a patient with pulmonary hypertension, severe pulmonary hypertension, or I'm having a right side heart failure, transesophageal, transthoracic, and pulmonary artery catheter with continuous mixed venous oxygen saturation. So, what are our hemodynamic goals for critical cardiac surgical patients? Our hemodynamic goals are central venous oxygen saturation more than 70%, or mixed venous oxygen saturation more than 65%, mean arterial blood pressure more than 65 millimeter mercury, which varies from person to person according to the perfusion of each patient and original blood pressure, cardiac index more than 2 liters per minute per square meter, CVB from 8 to 12 millimeter mercury, left ventricular end diastolic area 6 to 9 square centimeter per square meter, it is indexed. Intrathoracic blood volume index 800 to 1000, global end-diastolic volume index 600 to 800 milliliter per square meter, pulmonary artery occlusion pressure from 12 to 15 millimeter mercury, and a diuresis more than 0.5 milliliter per kg per hour. We will revise all the hemodynamic goals, but our advanced hemodynamic monitoring tools to achieve those goals are echocardiography. The gold standard is transthoracic. If I'm having an intubated patient with good view in the intensive care, I can use also the transthoracic. But if I have the intubated patient in the OR or intubated patient with difficult transthoracic window, I will use a transesophageal. The second monitor is the pulmonary artery catheter, and the third group of monitors are the pulse contour analysis devices, which I am going to discuss rapidly. Echocardiography, as we all know, that it offers additional hemodynamic data over any advanced monitor. It can give you a lot of hemodynamic and anatomical and pathological data. It is a better guiding for volume and intraop therapy. It is a better guide for surgical decisions. It is rapid and easy to perform, especially the transthoracic one. However, it is expensive. It's an expensive machine, expensive transesophageal echo probe. It is not continuous, and this is a major difference between transthoracic or transesophageal echocardiography from the pulmonary artery catheter. However, continuous forms of transesophageal echo are evolving. Echo is operator dependent and needs experience and training. And transesophageal echo has its own complications. We have we can have an esophageal perforation. We can have trauma to the airway. We can have trauma to the esophagus. We may have gastric upset. So it has also its own complication. It is not without complication technique, but echocardiography is our first line. It's the first line examination. It confirms the diagnosis. It's confirming that my hemodynamic problem is cardiac in origin, and it denotes what is the etiology. It is left-sided failure or right-sided failure. I can apply, as you see downstairs, pulse width Doppler across the aortic valve and LVOT, and having the Doppler blood flow across the aortic valve. Cardiac cycle. It's a very easy and practical method of evaluating the contractility. Low VTI equals low ejection fraction and low fractional area change and low fracture shortening. Echo may not need measurement. I can detect hypocontractility by eyeballing. So what I am seeing is ejection fraction less than 20 to 25 without any measurement. However, I have many methods of measurement, and I'm going to focus on specific points of measurements which are practical to use in the perioperative period. One important measure of contractility that is evolving and easily used intraoperative is left ventricular outflow tract, VTI. I applied the Doppler across the left ventricular outflow tract, and I'm having a curve, Doppler flow across the VTI. I get the height of this curve and trace this curve to have the velocity time integral. A velocity time integral less than 10 centimeter. It is the average distance a blood cell is ejected during one cardiac cycle. So it's in centimeter. So LVOT VTI less than 10, it denotes that this is a failing ventricle, failing left ventricle, and requires urgent mechanical circulatory support. Also, I can find with transesophageal and transthoracic echo missed data or new data that evolved in the patient, like newly developed ischemic mitral regurg or newly developed segmental wall motion This is a transgastric mid-papillary showing a kissing signs denoting hypovolemia. But with monitoring of the volume, I am monitoring the contractility of the left ventricle, and this is a good contractility, although it's an empty ventricle. Also, I can monitor the segmental wall motion. I'm monitoring now the anterior wall of the left ventricle, the inferior wall of the left ventricle, the lateral wall of the left ventricle, area of the LED, area of the PDA, area of the circumflex. So I'm monitoring the function and the coronary supply and the volume from one image, and I can trace the endocardial border to get left ventricular in the diastolic area and in systolic area, and can have a monitor of contractility with the fractional area change. Also, I can detect unexpected shunts in persistent hypoxemia or persistent hemodynamic instability, and also detection of these shunts can improve the outcome of patient markedly. I can have also measurements. I'm just having a rapid review of what data can I get from echo, but data obtained from echocardiography cannot be summarized in a simple presentation. It's a very large number of data I can have and very large number of information. So I'm just focusing on the rapidly on the most commonly used. I can trace the left ventricular in diastolic and in systolic area, and have the fractional area change, which is normally more than 50%. It's a monitor of contractility. I can trace by M mode the left ventricle in the systolic and in diastolic diameter, and to have the fractional shortening, which is a good monitor of contractility. I can have trace the endocardial border in the 4-chamber view and the 2-chamber view, to have the in systolic volume and in diastolic volume, and to obtain the stroke volume and the ejection fraction, which is also a very commonly used monitor of contractility. I can measure the cardiac output by tracing the aortic valve, tracing the triangularly opened aortic valve, and applying Doppler across the aortic valve to have Doppler flow across the aortic valve. By tracing it, I can have velocity time in febrile, and as we all know, heart rate, cardiac output equals heart rate times stroke volume, and stroke volume equal cross-sectional area of the aortic valve times VTI across the aortic valve. Also, I can assess the diastolic function of the heart by applying Doppler across the mitral valve, and to have the E and A waves of the transmitral Doppler. It denotes impaired relaxation or pseudonormalization or restricted filling pattern. Then I can apply tissue Doppler at the mitral annulus to have the E prime and A prime. If I have E prime and A prime, by making a ratio of the E over E prime, E of the transmitral Doppler over the E of the tissue Doppler across the mitral annulus, I can have an E to E prime ratio, which is significant to diagnose high filling pressure in this ventricle. So the ratio here is 0.85 over 0.1. The ratio is 8.5. Normally, the ratio is less than 8 in normal filling pressure. If it is more than 14, it denotes a high filling pressure in this atrium, and high pulmonary capillary wedge pressure is expected in this situation. So echo is rich, and echo is our first line now, and the transthoracic, if applicable, is very nice. If you cannot have a good image, you can use a transesophageal echocardiography, and transesophageal echocardiography can give you a lot of information. So this is our first line for hemodynamic, advanced hemodynamic monitoring. The second line is the pulmonary artery catheter, and intensivists are saying that it is obsolete and it is not used, but I have a different opinion, and many of cardiac anesthetists have a different opinion. Pulmonary artery catheter use is decreasing, but cannot be replaced until now. It is the gold standard for cardiac output measurement. It is the gold standard for continuous monitoring of critically ill patients. It is very, very valuable in patients with right-sided heart failure and severe pulmonary hypertension. Without the assistance of pulmonary artery catheter, you can lose, or you will lose, a lot of those patients because you cannot optimize the volume and the inotropy in such patients. As Professor Samir Ansari discussed, how to insert a route of insertion of this pulmonary artery catheter through the right internal jugular, and it's the easiest route, and insert through a sheath into the right atrium. Here I'm having the right atrial and monitoring the pressure. So this is right atrial pressure. Then I go to the right ventricle. I'm having a systole and very low diastole, nearly zero, and so denoting right ventricle. Then with inflation of the balloon, I go to the pulmonary artery. It floats with the blood flow into the pulmonary artery, making a systole and diastole. It's about 25/10. And then I go to the pulmonary wedge pressure, which denotes it's a pulmonary capillary wedge pressure, which denotes the left atrial pressure, and usually it is 10 to 12. So this is a pathway. It can monitor, can insert it guided by the pressure tracing, or can be inserted guided by transesophageal echocardiography, or can be inserted guided by fluoroscopy. Choose what is available in your center, but it can be inserted easily in most of the cases. What data I can have from pulmonary artery catheter? I can have the cardiac output and cardiac index, stroke volume and stroke volume index. I can have mean arterial pressure. I can have systemic vascular resistance and systemic vascular resistance index. I can have the pulmonary vascular resistance and pulmonary vascular resistance index, left ventricular stroke volume, stroke work index, and right ventricular stroke work index, oxygen delivery and oxygen consumption, oxygen extraction ratio. These are the oxygenation dynamics, oxygen parameters, which are very variable in pulmonary artery catheter. It is a gold standard. We get a continuous useful hemodynamic data during surgery and post-operative, but it has its own complications which limited its use. Complications include arrhythmia, especially with insertion, or maybe it's with prolonged stay. Infection, like any line, catheter-related infection, pulmonary artery rupture and severe pulmonary hypertension or severe trauma. It may cause valve injury in few cases, knotting and thrombosis, embolism, technical errors, thermistor malfunction, clotting, coiling with the catheter. Misinterpretation of the data is another risk, especially in junior colleagues. However, I inserted the pulmonary artery catheter for 10 years. I did not find a major complication. The most common complication that happened with me is misinsertion. Sometimes it cannot insert it into the pulmonary artery, especially with tricuspid regurg, or sometimes it's directed toward the inferior vena cava and doesn't go to the pulmonary artery. This is the most common complication I have seen, and the other complication may be misinterpretation of data. Sometimes that may happen. However, it is still a very valuable tool in cardiac surgery, especially in right and left-sided heart failure, especially with complex procedure, including CABG and valve surgery with pulmonary hypertension. Let us go to the third mode of advanced hemodynamic monitors. It's a pulse control devices, calibrated like the PICO and LEDICO, and uncalibrated like the flow track, and non-invasive like bioimpedance cardiometry, for example. I will take the PICO as a start. The calibrated devices are transpulmonary thermal dilution devices, include the PICO monitor. What data I can have from the PICO is cardiac output, global end-diastolic volume, global ejection fraction, intrathoracic blood volume, extravascular lung water, pulmonary vascular permeability index. PICO is very valuable for assessing permeability of the lung capillary membrane and extravascular lung water, also with the contractility and preload. However, accuracy of PICO may be affected by vascular compliance, use of large doses of vasopressor, aortic impedance, air bubbles in the system, clotting of the catheter. valvular regurgitation, which is a major issue because these are critically ill patients who need hemodynamic monitors. So my hemodynamic monitor will not be accurate in this situation. Aortic aneurysm, significant arrhythmias, which are very common in cardiac surgery, and rapidly changing temperature. Many validation studies was done for PICO with pulmonary artery catheter, and it was fine with the exception of off-pump coronary artery bypass grafting. Here is the PICO system where I insert a central line and I insert a femoral arterial line. Then I connect the central line with the femoral line through a temperature interface cable. I inject saline, cold saline through the central line. I sense the change in temperature through the femoral line through this cable. So it's an idea similar to that of pulmonary artery catheter on a larger scale. Then I have the transducer, which is connected to the monitor. So I have a central and femoral artery are main components of the PICO system. What data can I have from PICO? The valuable data of pulmonary vascular permeability index and the extravascular lung water. These are very specific for PICO and very advantageous in the PICO system. So I can detect increased intravascular lung water, normally less than 10 milliliter per kg. It increases in case of hydrostatic pulmonary edema and ARDS. The pulmonary vascular permeability index differentiates between hydrostatic pulmonary edema and ARDS. So it's very valuable for assessment of lung water. Also detect cardiac output by pulse contour analysis, stroke volume, pulse pressure variation. We can detect cardiac function index and global ejection fraction. It's an estimate of the global function of the heart, normally 25 to 35%. Cardiac output measured by transpulmonary thermodilution, which is an intermittent, not continuous like that measured by pulse contour analysis. Global end-diastolic volume, which is volume of blood in the four chambers of the heart. It's an estimate of the heart volume and the estimate of the volume status of the patient and index of the preload. Also combined with the lung or the pulmonary vascular permeability and extravascular lung water, I can define cardiac from non-cardiac pulmonary edema or congestion. The second system is the LIDICO, which is lithium dilution cardiac output. It combines pulse contour analysis with the lithium indicator dilution for continuous monitoring of stroke volume variation. Was validated against pulmonary artery catheter, but also it's affected in valvular diseases and aortic regurg, aortic reconstruction with the use of intra-aortic balloon, damped arterial line, severe peripheral vasoconstriction, arrhythmias, and intra and extra cardiac chunks. It requires regular calibration. Its use in cardiac surgery is much less than PICO system. Uncalibrated devices like the flow track system, quite popular in cardiac surgery. It's an easy assessment of the hemodynamic status of the patient. It does not need external calibration. It is operator independent, easy to use. The software analyzes the arterial pressure waveform and uses this analysis with the patient-specific demographic data, height and weight, to calculate the cardiac output and stroke volume variation. We found a good agreement between flow track and pulmonary artery catheter in patients undergoing OPCAB, and accuracy is affected in altered vascular tone and problem with arterial waveform. Here's a demonstration of what flow track can give you: cardiac output and cardiac index, stroke volume and stroke volume variation, systemic vascular resistance and systemic vascular resistance index. And some types you can put a fiber optic filament to detect the central line venous oxygen saturation, which adds to the hemodynamic data of the flow track. However, these pulse contour analysis devices are very, very affected by arterial waveform. And if I'm having severe vasodilatation or severe vasoconstriction, I will have a major problem in analysis hemodynamic variables. Also, it's affected by valvular regurgitation, especially the lead ecosystem and the PEEK ecosystem. And also, it has a major problem when I use a mechanical circulatory support device. And this is an important issue because mechanical circulatory support devices are increasingly used in cardiac surgery and are the future of cardiac surgery. So it's not, I think there are more studies are needed in this area to define the role of such pulse contour analysis in such devices. However, the gold standard in patient on mechanical circulatory support are the echo and the pulmonary artery catheter, which is very useful in such situation. In a study published in 2016 by the Society of Cardiovascular Anesthesiologists found that pulmonary artery was used by 68.2 respondents for cardiac anesthesia in more than 70% of time, and it was usually associated with the use of transesophageal echocardiography. However, from the commercial angle, there is a negative annual growth of 2% in the sales of pulmonary artery catheter, while a 15% positive growth of the sale of new cardiac output monitoring devices. Let us discuss algorithms for management of left-sided and right-sided heart failure, and see what monitors how the monitors, advanced monitors, can help us for this issue. If we have a left heart failure and we are using advanced hemodynamic monitor, either TEE or pulmonary artery catheter or pulse contour analysis, or the combination of the three. On the left side, we have left ventricle end diastolic area index less than 5. We're expecting it from 6 to 9. Pulmonary artery occlusion pressure less by the pulmonary artery catheter less than 5 millimeter mercury. We're expecting it from 10 to 12. Intrathoracic blood volume index, which is blood inside the thorax, heart, and the chest wall, less than 750. Which is usually from 800 to 1,000. So I'm having definitely a hypovolemic patient with left-sided heart failure. He needs preload optimization. I will give him volume to achieve my target goals, which are mixed venous oxygen saturation more than 65%, central venous pressure oxygen saturation more than 70%, mean arterial pressure more than 65%, cardiac index of 2, CVB 8 to 12 millimeter mercury, and our hemodynamic data we discussed before, and lactate less than 3 millimole per liter. But if I have a left ventricular end diastolic area index by the echocardiography between 5 and 7, and pulmonary artery occlusion pressure less than 10, and intrathoracic blood volume index less than 8.5, it is the lower range of normal. It is the lower normal range of volume. So I may benefit from preload optimization, and I may benefit from intropes. So I will try volume challenge, and I will use inotropes, dobutamine, or phosphodiesterase inhibitors, or epinephrine. And sometimes we need norepinephrine with phosphodiesterases or dobutamine. Okay, if I have a left ventricle end diastolic area index less than 9, between 7 and 9, which is the normal range, it's expected to have a good hemodynamics at this range, and have pulmonary artery occlusion pressure less than 15, and intrathoracic blood volume index less than 1,000 by PEEK system. So I should have a good hemodynamics. But if I do not have good hemodynamics, I don't need volume. I need inotropic increase. I will use a combination of epinephrine alone, levosimendan alone, or dobutamine or phosphodiesterase inhibitors. And remember, with the inodilators, many times I need norepinephrine with them. But if I have a left ventricle end diastolic area index more than 9, or the pulmonary occlusion pressure more than 15, and intrathoracic blood volume index more than 1,000, I'm having hypervolemic patient, so I need a preload reduction. I will use inotrope and inodilators. Either I will use epinephrine plus phosphodiesterase inhibitors, or levosimendan, and I do not use vasopressors in this situation because I don't want to increase the afterload on this overloaded heart. My goal values are discussed, and by achieving, if I achieve my goal values, I will evaluate my therapy. If I do not achieve, I will optimize my therapies again, or look for surgical correction, or use of intra-aortic balloon, or use of assist devices to correct the left-sided failure. Let us go to the right-sided failure. I will use the advanced hemodynamic monitor. I will use my advanced hemodynamic monitor. I will use the T1 transesophageal or the pulmonary artery catheter. I did not mention anything about the PICO. These are the most valuable things, and the PICO readings will not be valuable if I have discrepancy, major discrepancy between the right and left side. If my patient is hypovolemic, which means that the pulmonary artery occlusion pressure is higher than the central venous pressure, I will increase the preload. This can be diagnosed by transesophageal echo by finding low right ventricular filling volume or pulmonary artery catheter. However, if I find that pulmonary artery occlusion pressure is less than the CVV pressure, or rapid increase in pulmonary artery occlusion pressure, or I find by transesophageal echocardiography right ventricle dilatation, I will assess the hemodynamics of the patient. Is he hypotensive or is he normotensive? If he is hypotensive, I will add inotropy by catecholamines and inodilators, plus increasing the peripheral vascular resistance. Okay, so and in pulmonary hypertension, I will use inhaled vasodilators. So my choices will be dobutamine, phosphodiesterase with norepinephrine to maintain a good perfusion pressure. I can add epinephrine to this combination. In pulmonary hypertension, inhaled nitric oxide or inhaled prostaglandin. So if I'm hypotensive, I will add an inodilator with vasopressor, and I may add epinephrine to this combination. In normotensive, I will add inotropy plus afterload reduction with vasodilator. So I can use dobutamine or plus or minus phosphodiesterase inhibitor and maybe nitroglycerin. But in pulmonary hypertension also, I will use inhaled vasodilator to decrease the right ventricle afterload. My goal values are the same goal values for hemodynamic optimization. If it's achieved, I will evaluate my therapy. If it's not achieved, I will look for surgical intervention, intra-aortic balloon, and assist device. So this is algorithm how to use transesophageal echo, pulse contour analysis, pulmonary artery catheter to guide my volume and inotropy therapy in critically ill patients. Intra-aortic balloon pump is used post-aortically if I'm having a persistent worsening left low cardiac output syndrome despite treatment with high dose of inotropes and vasoactive substances, ST elevation with new evidence of hypokinesis without an option for surgery or intervention or correction, or problem in the anastomosis that cannot be corrected, inadequate revascularization. If achieved hemodynamic stability by the balloon, I will reevaluate it. If not achieved, I will consider the more aggressive intervention with the assist device. Finally, I'll say my conclusion. My conclusion is derived from a study by Vincent et al. In critical care, but it applies to non-cardiac surgery and cardiac surgery and intensive care. Cardiovascular monitoring systems play an important role in optimizing perioperative hemodynamic management. Use of hemodynamic monitors devices per se does not prove the outcome, but appropriate measurements and interpretation of cardiovascular variables help to guide the therapy with interventions, which will finally improve the outcome. Most appropriate systems must be selected for the individual patient. Every patient has his own monitor, his suitable monitor, and this decision is taken prior to surgery, taking in mind the individual risks of the patient and the procedure. Appropriate interpretation of the information offered by the hemodynamic monitor require the integration consideration of several variables, and echocardiography is increasingly used as a first tool to identify problems. Although pulmonary artery cancer is decreasing, but it has still a major role in critically ill cardiac surgical patients, specifically, not general intensive care patients. And thank you.
Wow, it's very course rather than a lecture. Thank you, Dr. Mani. Very nice talk.
Thank you, and I'm pleased to be with you in
Please all moderators to mute the phone, please. Hello, hello, please all moderators to mute the hello. Please all moderators to mute their devices, please.
Now, we will move after this very nice talk from Professor Mani Salah, which is really a mini course rather than a lecture, from my dear beloved colleagues, Professor Muhammad Rifat al-Tahab, a professor of anesthesia and surgical intensive care in Mansoura University and associate professor of cardiothoracic anesthesia in Imam Abdurrahman bin Faisal University in TSA, and he will present the title of Enhanced Recovery After Cardiac Surgery. So please go on, Professor Muhammad.
Thanks so much, Professor Mani, for a nice presentation, nice introduction, and Dr. Yes, it's fine, thank you. Ladies and gentlemen, I want first to express my appreciation and thanks to Dr. Mani and the organizers for the course, for this great organization, for the successful course indeed. And during the upcoming minutes, I talk about enhanced recovery after cardiac surgery. I want to draw your attention. If you have any question, you can type your questions in the question and answer area. Also, there will be polls included during the talk, so you need to click to vote on these polls to share your experience. First, I disclose I received the free AV device samples from Apple and AirTrack in 2014 and 2015 for use in 3 published studies. I have no financial interest with AMBO, AirTrack, or any other industry in the context of this talk or my studies. The first poll, Dr. Saad, have you ever provided care for patients undergoing cardiac surgery? Are you providing care for cardiac surgery, anesthesia for cardiac surgery? Yes. No, I don't know. You can click in your vote, please.
Okay. Good share now.
Please.
Okay.
Interestingly, 63% of voters are practicing cardiac anesthesia, which is very interesting indeed. And we have the other respondents, 36% are not practicing cardiac anesthesia. However, I think it is a good opportunity to know about cardiac anesthesia during this very interesting course after the previous 2 very interesting and informative talks and discussions. The objective of this talk, I will address what we mean by ERAS, enhanced recovery after surgery, ERAS in thoracic surgery as an example, and how far we have come regarding cardiac surgery, the potential benefits from enhanced recovery after cardiac surgery, protocols for enhanced recovery after cardiac surgery, and where does evidence stand for these protocols, and what will happen in the present and future during COVID pandemic. What does ERAS stand for? Enhanced recovery after surgery. It is an evidence-based care improvement process. So it should be evidence-based. It is provided for surgical patients that could get benefit from a of surgery, not cardiac surgery, for any other type of surgery, for gynecological, oncological, thoracic, urology, yes, no, I don't know. You can click on your vote, please.
We have it now.
It's very interesting indeed to find 60% of respondents have unimplemented protocols for enhanced recovery after surgery. It's very interesting. The second poll, do you have the third poll, do you have an implemented protocol for enhanced recovery after cardiac surgery? If you are practicing cardiac surgery at your hospital, yes, no, I don't know. That's also very interesting to find 1/3 of respondents have an implemented protocol for enhanced recovery after cardiac surgery. Because as I'll show you, this enhanced recovery protocols after cardiac surgery started just in 2017. So to have 1/3 of respondents have unimplemented protocols, it's a very interesting thing. I'll move now to, is it time to change our practice if we are not practicing enhanced recovery after cardiac surgery? Actually, yes, it is a change ahead and it is time of changing. There are a lot of editorials and review articles about it is a time to change to enhanced recovery after surgery. And this is one of the earliest implemented suggested protocols. And you can see all of protocols are based on preparing and optimizing conditions of patients starting from pre-operative period, and you will continue this during intraoperative and extended to post-operative periods. So what the other specialties are doing now? If you look for the close subspecialty to cardiac anesthesia, which is thoracic anesthesia, this is an interesting study for economic impact for enhanced recovery pathway after lung resection for lung cancer. And this is enhanced protocol. This is a small study. It's including about 150 patients or less. And here regarding the economic impact, I want you to focus on this. You can see we have a reduced operative room cost here. We have a surgical ward stay. There is the reduce of cost, intensive care stay, the cost of drugs for pharmacy, as well as institutional cost for other assisting services, as well as healthcare system cost, and also societal cost. If we calculate this decreases in cost with implementing enhanced recovery after cardiac surgery, you can see in this study there are saving of 12,000 above dollars for care of patients. This is not a small amount, it is a large amount, and it could be invested for caring of other patients. And also for the same protocols for enhanced recovery for lung cancer surgery, the systematic review and meta-analysis, including randomized control studies, they found that overall mortality is favoring lower overall mortality was favoring of enhanced recovery after lung surgery. The mortality is less. Additionally, complications is less, but particularly pulmonary postoperative pulmonary complications, which one of the most common night dreams and nightmares for thoracic anesthetists. So the enhanced recovery protocols after thoracic surgery doesn't translated into only the reducing in cost of healthcare, but also extending to improving clinical outcome in terms of lower mortality and lower post-operative pulmonary complications. How far we have come regarding enhanced recovery after cardiac surgery? We are not too far from thoracic, but we are too far from implementing of ERAS, a concept of ERAS, enhanced recovery after surgery, in 2001. Actually, after there was an inaugural enhanced recovery symposium, which is held in Boston in 2017. And this is a meeting for development of the Society for Enhanced Recovery After Cardiac Surgery. It was the first interest, gaining interest of different experts. It was in the United States in 2017. This is an interesting study starting before developing of evidence-based protocols. This is a small study, and including two arms, to study arm for enhanced recovery protocols and traditional or conventional approach. The enhanced recovery protocols including robotic totally endoscopic coronary artery bypass graft. And you can see here, which is a more important to look for a clinical outcome, the using of ERAS with the robotic assisted approach associated with decrease the length of ICU stay and hospital stay. You can see the length of ICU stay decreased by 1 day and 4 days for hospital stay, which means a lot of saving in healthcare cost. Someone could claim reducing the hospital stay and the ICU and enhanced protocols could be associated with worsening myocardial function or increasing the risk for myocardial ischemia, particularly with fast track cardiac surgery and so fast or too early extubation of patients. You can look for troponin levels at 6 hours and up to 24 hours after enhanced recovery protocol with robotic approach is significantly less during the 6 hours, and also this is extended to 24 hours after cardiac surgery. However, this is a retrospective study, and as I told you, it is a small study. It is a pre and post study. What are the potential benefits of implementing or developing protocols for enhanced recovery after cardiac surgery? Enhanced recovery after cardiac surgery could be associated with decreased perioperative stress responses, which is translated into shorter ICU stay, shorter hospital stay, lower post-operative complications in terms of the intensity of post-operative pain, the rate of post-operative infection and wound infection, sternal dehiscence, cardiac events, pneumonia, and even bleeding, cerebrovascular accident, acute kidney injury, and other surgical complications. Also, there are area function recoveries. That's meaning the patient can return to normal and functional status earlier than other patients. This is translated into less cost and improved outcome. We have to ask ourselves, can we do the job? Probably, if we are going to develop protocols for enhanced recovery after cardiac surgery. Interestingly, in last August in 2019 in JAMA, there is published guidelines from Iraq's Society, Enhanced Recovery After Cardiac Surgery Society, about guidelines for perioperative care of cardiac surgery, enhanced recovery after surgery, and this is the society recommendation. As I told you, this protocols based on preoperative, intraoperative, and postoperative period. For before surgery, I'll discuss each items later on in details. Alcohol and smoking cessation, monitoring of hemoglobin A1C, and control the level of diabetes for in case of uncontrolled diabetic status, correction of nutritional deficiency, avoidance of prolonged fasting. You have to minimize the hours of fasting, patient engagement technology, as I'll show to you, rehabilitation. For intraoperative period, routine using of antifibrinolytics, except if it is contraindicated, should be encouraged. Avoidance of hyperthermia after discontinuation of cardiopulmonary bypass, infection reduction bundle, and minimize the risk for mediastinitis, wound infection, sternal dehiscence, and need for resurgery. Optimization of sternal closure, this is very important. Also, after surgery, avoiding of hypothermia after transferring to after conclusion of surgery and transferring patient to ICU. Monitoring of biomarkers for acute kidney injury to early identifying patient with acute kidney injury and minimize the need for dialysis on the long-term chronic kidney disease. Chest drain management and regular delirium screening at least once per nursing shift. Early extubation. Glycemic control should be continued from the pre-operative period to post-operative period, as Professor Maged Salah had described, using goal-directed therapy, either using any of minimally invasive cardiac output monitoring or just using a simple algorithm with mean arterial blood pressure, central venous pressure, and mixed venous oxygen saturation, multimodal analgesia, and thromboprophylaxis. We have to look for the levels of evidence and the level of recommendations for these recommendations. You can see here on the cursor the highest recommendation, which is class 1 and level of evidence of A, tranexamic acid or epsom aminocaproic acid is recommended during on-pump cardiac surgical procedures. It should be used routinely in all patients except of contraindications. The most common contraindications if you have a patient with uncontrolled seizures, convulsions, or patients with high risk for CVA and stenosis or stenotic lesions and carotids. The level 1 also, based on randomized controlled studies, more than one study, perioperative glycemic control is recommended. So it is also high evidence. Adapting a care bundle for evidence-based best practice to reduce surgical site infection, starting from the removing of hair as close as time of surgery, washing of skin with chloroxetine soap, and administering prophylactic antibiotic within 30 minutes from insertion of central line and skin incision. This is high level, also based on randomized studies. Goal-directed therapy, as described by Professor Maged Salah, is recommended to reduce post-operative complication. There is no restrictive fluid therapy. There is no liver fluid therapy during cardiac surgery. Also, a high level, which is a level 1 evidence, but based on non-randomized study or small randomized study, is a multimodal opioid-sparing approach for pain management. That's meaning you have to use different modes with reducing the opioid use increasingly, but it is not included in the guidelines. And there is effects for using of some marginal blocks for post-sternotomy pain. Also, a level 1 evidence, persistent hypothermia after cardiopulmonary bypass should be avoided, at least in the early post-operative period. Also, it is based on non-randomized studies. And also, there is here maintenance of chest tube patency. It is a very important and recommended to prevent clotted blood to occluding it. Additionally, maintenance of chest tube post-operative systemic delirium screening using some screening tools. There are several screening tools are available. It should be recommended at least once per nursing shift. That's meaning at least 3 times per day for the first 3 to 4 days after cardiac surgery using cardiopulmonary bypass. The next one is also level 1, which is based on observational studies and low evidence, is smoking and hazardous effects of alcohol use, and should be stopped 4 weeks if it is applicable. Usually we acknowledge that is not possible for most type of cardiac surgery. Other recommendations level 2A, including early detection of kidney stress and interventions to avoid acute kidney injury, are recommended following surgery based on randomized studies. Rigid sternal closure using different type of closure techniques, figure 8 plates or others, is useful to improve and accelerate sternal healing and reduce the incidence of dehiscence after cardiac surgery. Also, class 2A, including rehabilitation, is recommended for patients undergoing elective cardiac surgery or multiple comorbidities, or if there is a significant deconditioning. I'll show you later on an examples of rehabilitations. Another one based on non-randomized study, which is level 2A, insulin infusion is recommended to treat hyperglycemia in patients post-operatively. And similarly, strategies to ensure extubation within the first 6 hours after cardiac surgery is highly recommended. There is also level 2A recommendation, but based on observational studies, patient engagement tools, including you can providing for your patients online virtual protocols, educational videos, interviews, and you have to to demonstrate the patient's compliance with the regulations after surgery, and the patient reported outcomes which will be improved with this technique. Level 2 also based on observational studies, including chemical thromboprophylaxis against the risk for deep venous thrombosis and pulmonary embolism. Also 2A levels, the pre-operative measurement of hemoglobin A1C is recommended to assess for risk stratification. And the pre-operative correction of nutritional deficiency is recommended when feasible, and you have time for this. Less evidence, which is level 2B, including clear liquid should be continued up to 2 to 4 hours before surgery. There is no meaning to ask patient to stay fasting for 8 hours or 10 hours before surgery. Additionally, preoperative carbohydrate loading may be considered up to 2 hours before surgery. And additionally, for this one and level 3, no benefits was shown with stripping or milking of chest tube to remove the clots or to stir the sterile area of chest tube insertion. There is no benefit from this practice, so we should avoid it. Also, there is a harm which is based on randomized studies, that's meaning strong evidence. Hyperthermia more than 37.9 centigrades during rewarming after cardiopulmonary bypass is potentially harmful and should be avoided. There is an aerial protocol described from this group of investigators 2 years earlier than JAMA paper. And you can see here is including also pre-operative period. They looks like the same recommendation for Iraq's society. However, if you can look here, they added some important items like methicillin-resistant Staphylococcus aureus screening, which is a very important, use of antiseptic soap before surgery, oral administration of statins, and we have to look for evidence for this. Also, for day of surgery, it is similar to avoid long fasting, carbohydrate load. However, interestingly here, using anxiolytics to minimize anxiety, and you shouldn't consider using of benzodiazepines and minimize the use of opioids for geriatric patients older than 70 years. For intraoperative period, it is also similar to Iraq's protocol, except of the adding a routine anti-inflammatory therapy, aggressive use of vasoactive medications to avoid hypotension, and then as the risk for post-operative cognitive dysfunction, complications, CVA, and minimally invasive monitoring as described by Professor Magid, and using minimal invasive approaches as described by the earlier studies on robotic assisted CABG. For following surgery, it is very similar also to the Iraq's protocol. However, if you take a look here, they included protective ventilation based on driving pressure and using alveolar recruitment strategy or maneuvers, facilitation of gastrointestinal function recovery, including this as recommendations. Next, we have to look where does evidence stand for regarding every one of these recommendations. First, if we take a look here for risk stratification, there is a growing evidence of the efficacy, feasibility, and validity of using Euroscore 2 and also SAPS-3 as predictors for risk stratification before cardiac surgery. So it is very important to calculate Euroscore 2 before going raised prior myocardial infarction, previous cardiac surgery, emergency surgery, combined procedures, or coronary artery bypass graft for left knee coronary artery disease, obesity, we cannot deal with this. However, we have some modifier factors here on the right side, like uncontrolled congestive heart failure. You have to consider using of diuretics, ACE inhibitors, to do the beta blockers before surgery, to optimize the cardiac function as much possible as we can. Control of uncontrolled diabetes, control uncontrolled hypertension, alleviation of the incidence of chronic kidney disease, management of atherosclerosis, that cessation of smoking, and if you have any patients, as Professor Samir described, you have to correct it during the pre-operative period and consider blood conserving strategies. So we have to look for other items for recommendation, infection, and outcomes. In this study, including 2,100 patients undergoing coronary artery bypass grafting, the secondary is looking for incidence of surgical site infection. Patients who develop two-thirds of them develop surgical site infection. More patients who developed skin surgical site infection needed to be admission within 65 days of surgery, 2 times more than non-patients without surgical site infection. However, interestingly, there is no significant decrease in 65-day mortality among patients with or without secondary surgical site infection, which is interesting. Regarding preoperative nutritional optimization, this is study including 787 patients undergoing valvular CABG or combined procedure, and 60% of these patients received artificial nutritional support during the preoperative period. 3/4 of them received enteral nutritional alone, 70% received combination of enteral and parenteral nutrition, and 5% received parenteral nutritional alone. We have to look into the outcomes of this study. There is increase in energy intake, and protein intake is not significant with unadjusted odds ratio. However, the most important here, post-operative cardiac surgery patients who stayed longer in ICU for 3 days or longer were at high risk for inadequate nutritional therapy. So patients who exhibit or presented with the signs of nutritional deficiency, you have to select. If you are not going to correct this deficiency, the patient might stay longer in ICU. This is a small study indeed, however, it is important primary outcomes, including about 100 patients, and the preoperative malnutrition was identified as a predictor for early post-operative delirium. So malnutrition doesn't translate only in prolonged stay in ICU, but might be translated into more risk for post-operative delirium after on-pump coronary artery bypass graft. Regarding preoperative physical activities, this is a meta-analysis systematic review including 11 studies and multiple tools to measure physical activity, but they didn't conclude and to do quantitative analysis and meta-analysis. However, later on, in 2 years ago, this is the meta-analysis including 17 randomized controlled trials. 12 of these randomized controlled trials were addressing for post-operative pulmonary complication and included in meta-analysis. 11 studies included for meta-analysis for the length of stay after cardiac surgery. Interestingly, inspiratory muscle training using this device, you must know this device is called inspiratory muscle training incentive spirometry, and patients receiving inspiratory muscle training reduce the risk for post-operative pulmonary complication and also the risk for hospital stay, which is a very significant AD. Regarding preoperative statins, if you remember, this is area guidelines, they including routine using of statin therapy, but this doesn't no difference in terms of mortality for low risk of bias trials or even for all trials. There is no difference in the risk of mortality with using or non-using of statins during the pre-operative period. More interestingly and worrisome indeed, patients receive statins associated with it wasn't protective first against atrial fibrillation, myocardial infarction, stroke, or infection. However, it is a very worrisome that there is increase of acute kidney injury after pre-operative using of statins before cardiopulmonary bypass. Glycemic control. This is a study including 760 patients, and they divide the patients according to the level of hemoglobin A1C, either less than 6.5 or equal or greater than 6.5%. You can see there is no difference in the risk of complications, myocardial infarction, bleeding, deep sternal infection, stroke, pneumonia, renal failure, terminal death, or atrial fibrillation. Now, the next one, Dr. Saab, please. When are patients extubated after cardiac surgery at your institution? If you are practicing cardiac anesthesia, immediately on operating room table. Number two, less than 2 hours from admission to from conclusion of surgery. Number three, 1 to 6 hours, or number four, 6 to 12 hours after surgery. Please click and vote on this about your practice. We have only 10% of respondents are extubating patients on tables. However, the majority of practitioners is about 70%, that's meaning about two-thirds or more than two-thirds of respondents are extubating patients between 1 to 12 hours after surgery. And only 13% are extubating patients before within 2 hours. That's also interesting. If we have another poll, if you are not going to extubate the patient immediately on table after cardiac surgery, what are your concerns? It is a major procedure. Cardiac surgery is a major procedure. Number two, risk for hemodynamic instability. Number three, risk for myocardial infarction. Number four, risk for post-operative bleeding. Number five, sternal operating under closure, there may be dialysis. And number six, need for reintubation, particularly with using high dose of opioids. Number seven, severe post-operative pain. Why you are not extubating patients on table after cardiac surgery? Can you click on your vote? That's very interesting. Half of respondents, they are concerned about the risk of hemodynamic instability. Let's say one of the standard golden criteria for extubating patients after cardiac surgery is that in table or in ICU to have a patient with hemodynamic stability on no or low rate of fusion for intravenous and vasopressors. So we are not expecting to extubate patients with hemodynamic instability. Let's see about the major procedure. Okay, cardiac surgery is a major procedure, but what's about thoracic surgery for neonatomy? We are extubating patients on table. What's about neurosurgery cases with extensive brain tumor resection from base of the skull lasting for 12 hours or longer? We are extubating patients on table. So major procedure itself doesn't preclude the need for the indication for immediate extubation after cardiac surgery. What's about the risk of myocardial infarction? Should you be disruption is not risk. I'll show you more evidence now. Risk for post-operative bleeding. Okay, this is a good concern. But let's discuss it. If you have a patient after thoracic surgery, after pneumonia, and there is disruption of the ligature over the pulmonary vein, and you have horrible bleeding, would the patient will die? No. You will go into intubate the patient, restrict the patient, and take the patient back to our. It's the same for cardiac surgery. However, we have a concern and indications against immediate extubation on table after cardiac surgery if you have a patient which is tube out more than 50 milliliters during the last 30 minutes during and after conclusion of closure. External opening, you might need to explore the patient and to leave closure. You might be concerned about sternal dehiscence. Okay, this is indication to ask the surgeon to do a strong fixation. As I told you, this is not a big issue. Need for intubation and high dose opioid. In Iraqis, there is no more role for high dose of opioids. By using a very low dose of opioid or opioids with opioid sparing techniques like using of antagonist, ketamine, magnesium sulfate, or other combination of non-steroidal and non-steroidal anti-inflammatory drugs that is not contraindicated, or using paracetamol, stops, local infiltrations. We have different techniques. Same, it could be translated into a better quality of post-operative analgesia. Let's see what will happen here for fast-track cardiac anesthesia with using of short-acting anesthetics, opioids, and so on. It is one observation. So you have to choose between sending the patient to ICU, intubated and ventilated on sedations, and you have a longer time, or you have to offer for the patient from the beginning, from your consent, if the patient prefer to talk to family instead of breathing through tube, which is a priceless. When you extubate your patient following cardiac surgery, we have to look for evidence. What do we mean by fast-track cardiac anesthesia? Everyone will ask, will answer the question. Is 6 hours, within 6 hours after surgery. However, this is the recommendation from the Society of Thoracic Surgery, STS. However, it is a benchmark which is not based on histological evidence. It is just a consensus agreement. However, later on, in 2017, in this study with pre-protocol and post-protocol of early extubation of cardiac surgery patients, they found that the ventilation hours, of course, is less with early extubation, and interestingly here, ICU hours stay is associated is prolonged after keeping the patient intubated for 12 hours or longer after surgery. So it's not just hours. What about the risk of 30-day mortality and the risk for major complications except for the need for intubation? In this another study, they found that a time period of 6 to 12 hours is the cut point for more mortality and more post-operative pulmonary complications. So again, fast-track anesthesia, cardiac anesthesia couldn't be defined as extubation within 6 hours. However, the actual ventilation time that lead to increased complications exceed 12 hours. Okay, let's see for more recent study in 2018, which is a very strong study indeed, which is STAGE trial. STAGE trial is surgical treatment for ischemic heart failure, and this is a study including 14,000 surgical patients for cardiac surgery, cardiac surgery, and at 36 hours post-operation, 90% of patients were extubated. However, we have to look here, intubation time was the strongest in the predictor for 30-day mortality and even 1-year mortality. So if you're leaving your patient intubated and ventilated for longer hours, that means you are reducing the chances for this patient to survive not only at 1 month after surgery, but up to 1 year after surgery. This is another meta-analysis and systematic review, including patients, so 35% of them need ventilation for greater than 48 hours. There is no difference in ventilation time of shorter with those extubated area. However, this is very interesting here early extubation. Early extubation associated with less death in ICU, less death in hospital after surgery, less death of 1 month after surgery, and less death regardless the cause. However, compared with low dose opioids and here high dose of opioids, post-operative myocardial infarction, here is a concern if you remember suppose about the high incidence of myocardial ischemia is less with low dose of opioids. Our routine practice. The practice at our center to extubate the patient 6 hours or longer or to keep the patient ventilated overnight. Here we could succeed to extubate 60% of patients over table. We identify independent predictors for extubation, early extubation in table, including low Euro score and the changes in propofol, cumulative use of opioids, so fentanyl and the propofol. Here we compared the immediately patient 45 patients immediately extubated in table. This is one of them. This is post hoc analysis, and 26 were received conventional ventilation. We found some differences. Patient with shorter aortic cross clamp time, shorter cardiopulmonary bypass, surgical anesthesia and surgical times, readiness to extubation associated with more of them are associated with immediately are being immediately extubated on table. There is less risk for ischemic events, myocardial ischemic events with immediate extubation, less need for transfusion. This is not much significantly. You can see also we have higher opioid consumption with patient controlled analgesia with morphine, but it's not too much. It's just 4 milligrams. It's not of clinical importance. And interestingly, the hospital stay is reduced by 1 week. You can imagine decrease the cost of healthcare by 1 week. If we look again for other marker for myocardial ischemia, troponin level up to 12 hours after surgery were half of patient were immediately extubated than conventionally one. And the risk of bleeding also half of them have bleeding than patient received conventional care and post-operative ventilation. Perioperative fluid therapy, I would skip this one because Dr. Magid has explained it in details. However, I want you to look for this meta-analysis and systematic review, including 9 studies about the goal-directed fluid therapy associated with shorter hospital stay after cardiac surgery, and overall analysis revealed no significant differences in all-cause mortality, duration of mechanical ventilation, or length of stay. However, there is a shorter hospital stay, but not shorter ICU stay. Protective ventilation, if you remember the other group which implemented the area protocol in 2017, including protective ventilation. This is a systematic review and narrative senses which failed and showed low certainty and evidence with using intraoperative or postoperative protective ventilation approaches in cardiac surgery. Finally, about patient education. This is an example from Papworth Hospital. This is one of protocols to ask the patient to shrug shoulders and then to twist the trunk maximum as he can or she can, and leaning forward, doing inner range, straight leg raising, and middle inner range. This is the rehabilitation. You have to prepare the patient to move out of bed as early as possible before surgery. This should be started from educating your patient during pre-operative period. Additionally, sit to stand, doing squatting and sit up on a step or standing on heels and in front of feet are strengthening the calf muscles and reduce the incidence of thromboembolism and deep vein thrombosis. And now the question, what will happen in the future? You should know the WHO declared the pandemic for COVID-19 on March 11, 2020. And all scientists are expecting to have a second wave soon in winter. And we are concerned about this. We shouldn't and we cannot, for different economic and ethical issues, to stop elective surgery again. So we have to look if we can extend the using of enhanced recovery protocols after cardiac surgery during COVID pandemic. This is a very interesting review article and published about 20 days ago in Journal of Cardiothoracic and Vascular Anesthesia and Cardiac Surgery and COVID-19 patients compete for, as you know, they are competing for resources. So they are demanding for physicians to taking care and nurses to taking care of COVID patients, allied health care services, shortage in ventilators, in ICU bed, and continuous renal replacement therapy or extracorporeal life support, because these items are using for COVID patients. Also, we might be have a shortage in medications and nutrition for parenteral or total parenteral nutrition, vasoactive meds, or sedation meds, or blood products even. So we need to look if the protocol for the Society of Enhanced Recovery after Cardiac Surgery could be extended or be helpful for patients with COVID undergoing cardiac surgery, suspected or confirmed COVID. We have to look for, this is the items of including in the enhanced protocol of the Society of Iraqis. You can see about the expected benefit is expected to be high in one of the preoperative factors, which is using surgical site infection reduction bundle, would be helpful even for COVID patient. Intraoperative multimodal opioid sparing analgesia and hence extubating the patient area, free up the bed of ICU and reduce the need for using of medications and the light of drug shortage is also could be large benefit getting from COVID patients. Routine administer of intraoperative antifibrinolytics, as I told you, tranexamic acid or epsilon aminocaproic acid. There is a large evidence. Maintain intraoperative glucose levels below 180 milligram per deciliter, and this is also extended to the post-operative care. There is a large expected benefit in COVID patients. Also, if we took a look for avoid persistent, avoid hyperthermia and avoid hypothermia, would good benefit also for COVID patients. For post-operative care, again, post-operative multimodal opioid sparing analgesia, optimize strategies to ensure extubation as early as safely possible, and promote early mobilization and removal of chest tube drains, lines, and so on. All of this are expected to get a large benefit for COVID patients. At the end, the conclusion is this talk, enhanced recovery after cardiac surgery is the present and the future evaluation in daily practice. We should implementing systematic approach for Iraqis at our centers. If we don't have such protocols, there are several physiological and economic benefits from Iraqs, and the current evidence can support lot of or most of Iraq's recommendations for enhanced recovery protocols. However, we still in bad need for more longitudinal, larger studies to test the efficacy of this recommendation on different clinical outcome, like mortality for 1 year or longer, like hospital stay, ICU stay, cost analysis studies, and so on. Thank you so much for your listening, and I welcome your questions.
Thank you very much. Actually, amazing. Updated and wonderful, Professor Tahan. Now I can get a deep inspiration after these very nice talks from Professor Samir Al-Ansari, Professor Maged Salah, and my dear colleagues, Professor Muhammad Tahan. Dr. Saad, do we have some time to get one or more question, please?
I need to put one of your devices off, please.
Okay.
Yeah, you have echo and noise behind you. Okay. Yeah, we have 5 minutes more to go, please.
Okay, we do have a question for Professor Tahan.
Yes.
The question say regarding early extubation, even if the patient is hemodynamic stable, she's aware about the procedure duration. She said that the drip perfusion is not enough if the operation is more than 6 hours. She had the fear of risk of rebound hypothermia, increased oxygen demand, risk of rebound heparin effect, and consecutive bleeding. All these factors can lead to hemodynamic instability. She's in fear of early extubation in this situation. What's your opinion, Professor Muhammad
Okay,
Tahan?
thank you for the question. Actually, if we take one point to one point, if we look for a longer time of surgery, the most important predictor for early extubation or immediate extubation is not the duration of surgery itself, but the duration of aortic cross clamp and cardiopulmonary bypass. If you have aortic cross clamp longer than 120 minutes, if you have cardiopulmonary bypass time more than 180 minutes, this precludes the indication for immediate extubation on table. So it is not the whole time of surgery. For example, you have a patient undergoing pneumectomy for 8 hours or for 10 hours sometime, and also you might know about lung transplantation, single lung transplantation. There are many practitioners nowadays are extubating patients on table. So it is not a major issue. Regarding hemodynamic instability, reperfusion time, you have to consider good reperfusion time. You have to judge the patient's conditions, hemodynamic stability, parameters as described by Professor Magid Salah and Professor Samir. And if you are going with any tropes or vasopressors, and you have to judge all of this through multidisciplinary discussion with your surgeon and decide to extubate the patient or not. Regarding rebound hibernization, if we can consider this, if we are using focused monitoring for coagulation, point of care monitoring for coagulation, and if we are going to titrate protamine as much as heparin given, not higher, not lower, we are not expecting to have a rebound hibernization. Rebound hibernization, if it happens and you have medical bleeding, which is not significant, as described by Professor Samir, to less than 400 during the first hour or 200 in the subsequent a couple of hours, this doesn't preclude extubating the patient. You can correct, and if you have a patient who is already extubated and you don't have high volume of chest tube drainage, you can correcting the medical factors and coagulopathy different factors as described by Professor Samir and others. Regarding hypothermia, hypothermia, it could be continued, and during transferring the patient, we all know about the physiological draft of half to 1 centigrades after cardiopulmonary bypass. Here you have to stop your cardiopulmonary bypass with a temperature not less than 36.5, and you have to continue warming intraoperatively up to during transferring your patient to CCU, particularly if you are going to extubate the patient with using enforced air mattresses or water mattresses, warming mattresses. Otherwise, you cannot extubate the patient. I think I answered her points.
Thank you, thank you. And the last question for Dr. Tahan also.
Yes,
in
please.
In the literature, what are the most important monitors used in poor countries which can give you the fast tracking of in those type of patient? I mean in cardiac anesthesia. If I have to get a monitors with little money, which monitors you preferred in the literature which can give you this access?
That is a very important question. I think I answered it during my talk indirectly, and Professor Magid demonstrated that the using of the expensive technology of minimally invasive cardiac output monitoring, although I improve for using them, is not the standard of care nowadays. However, not only in low-income countries, I wanted to share with you that most of European countries nowadays are using routinely only arterial line and central venous catheter for a routine monitoring for cardiac surgery, except if you have a complicated cases, if you have lung transplantation, if you have cardiac transplantation, you have to consider using of pulmonary artery catheter. Of course, the indications for transesophageal echo during intraoperative course, there is no doubt about it. And there is a recommendations from different societies about the recommendations, particularly during valve surgery, or as Professor Magid described, in patient with right ventricular dysfunction or difficult weaning of bypass. However, routinely, in routine cases, for a fast track protocols, you can use only arterial line. If you take a look in a mechanically ventilated patient with tidal volume 7 to 8 milliliter per kilogram of tidal volume, and if you take a look for variations in the arterial waveform with the breathing, if you have this accentuated variation, this is indicated for hypovolemia if you are excluding other causes. If you have already low mean arterial blood pressure, as Professor Samir indicated, as I told also, you can take a samples, no need for continuous monitoring, samples from a mixed venous blood from a central line, and according to SSDVE2 as described in the protocol by Professor Magid and Professor Samir, we can judge the need for increasing of fluids or needing for any tropes, and according to hemoglobin level, this is a goal-directed therapy. You can define if you need to give a fluids or transfuse blood. This is in a patient with MAB 65, less than 65 millimeter mercury or less than 20% in hypertensive patients. And then decide to give fluids. If you have low mixed venous oxygen saturation, this is indicator for low cardiac output. And if you have optimized CVB, for example, you have to consider increasing inotropes. If you have normal mixed venous oxygen saturation and still have low mean arterial blood pressure and normal range of central venous pressure, you have to consider using vasopressors at this time. Of course, it is not a situation to talk about mechanical circulatory support, because if you are talking about you don't have the facilities for advanced monitoring, at least, so you don't think you have access for mechanical circulatory support.
Thank you, Professor Tahan.
Most welcome.
Finally, I have to say thank you very much, Professor Samir Al-Ansari. Thank you very much, Professor Magid Salah. And thank you for my dear colleagues, Professor Muhammad Tahan. And we have finally to say, we appreciate this mega online course. We have to appreciate and we have to thank Dr. Saad, Dr. Walid, Dr. Hisham. Actually, we get a lot of information. It's amazing, Dr. Saad. Go on, keep on. And my appreciation and for this invitation for this nice night. Thank you very much.
Thank you very much, Professor. We are so honored to have this number of professors tonight, and our guest here, Dr. Yasser Reda, Dr. Adil, and Professor Samir Ansari, Professor Magid Salah, and Professor Muhammad Tahan, and finally Professor Magdi Atallah. Thank you much for really successful night tonight. This episode, I think, is episode 40 of the Mega Online course, very successful. Next Sunday at 7 o'clock Cairo time, we have another day. We are looking forward for that day. It is intensive care day. Particularly, we are going to talk about sepsis. 4 eminent speakers about intensive care, and they are going to talk about sepsis and the guidelines and the bundles and the protocols. So keep tuned, keep attended, please, to next Sunday at 7 o'clock Cairo time. From myself and my colleagues, thank you much for being here today, and we are so honored to have this number of people here, this number of attendees, and this amount of support for our course. Thank you.
Thank you.
Thank you.
Thank you, everyone. Thank you, professors. Thank you.
Thanks, Dr. Reed. Thank you.